So now let us start with the part 2 of the traumatic PPH and episiotomy. So as we discussed in before video about the median episiotomy and mediolateral episiotomy. So what is median episiotomy? Actually the levator ani muscle will be on this like this sides, okay, and they'll become thin in the center like this, okay. So here there will be more fat, I mean this muscle will be fat, and here it will become in the center it will become thin, okay. This is the levator ani muscle, okay. So actually we cut the muscle in the center in the case of median episiotomy. First we'll discuss about median episiotomy, okay. So as you're cutting the muscle in the center, there will be less bleeding because the fibers which are in the center are somewhat thin, right? So healing also will be very fast, and even the dyspareunia will be less. But the disadvantage for this, why it is not used, is because it extends, if it extends especially during labor time, it can involve the anal sphincter also, because this cut may also extend on the back side towards the rectal side or anal side, and it will involve the anal sphincter, and that will lead to third or fourth degree perineal tear again. So it will lead to fecal incontinence, which is a very big problem. So this corresponds to 1 degree tear again, because in the 1 degree tear, if you remember, there is muscles of mucosal skin of vagina will also turn. So this is why we will not prefer median episiotomy, but we will prefer the mediolateral episiotomy. Why will prefer the mediolateral episiotomy? Because it will extend. If even though it will extend, it can never involve anal sphincter. So never involve anal sphincter. Why it will never involve anal sphincter? Because you can see here in this diagram, this is a median episiotomy. Here we are giving the mediolateral. As it is going laterally, it will never meet the anal side, so that's why it will never involve anal sphincter. But the disadvantage is here the more muscles are cut, because this is a lateral side. Lateral side here the thick muscle is very thick. The levator ani muscle is very thick. So more muscles are cut. So there is more bleeding. This is a disadvantage here. And the repair is also very difficult because more muscle fibers are present. And even the dyspareunia will be more. What is that? Dyspareunia is more. That is the pain during coitus will be more. But here the pain during the coitus will be less. Okay, and it is going to correspond with the second degree perineal tear. Why second degree perineal tear? Because here there is not only mucosal skin got damaged, but the muscles are also getting damaged here. Okay, so this is leading to tertiary or 4th degree tear. That's why we are not doing it. We are doing the secondary tear. Those are somewhat better. Okay, so now coming to indications for episiotomy. In what indications we need to do this? That is in the case of rigid perineum. If the perineum is rigid, okay, especially in primigavida females, and whenever there is shoulder dystocia, in that case, and whenever there is macrosomia, and whenever if the delivery after coming head of breech, in that case, and if you do instrumental delivery, okay, like forceps or vacuum, and if you do phase 2 pubis delivery, or suspecting perineal tear. So in this all these conditions we need to do the episiotomy. Not for every vaginal delivery we should do this. Now coming to hematoma. So what is hematoma? Hematoma, what is the most common site of pelvic hematoma? That is vulval hematoma. So on the vulval side there is most common site, and the most common artery of vulval hematoma is pudendal artery. Okay, and the most common artery to form vaginal hematoma is uterine artery. Everyone will think vaginal artery. Yeah, even vaginal artery is right, because uterine artery only will give rise to vaginal artery. Both are okay, but we will usually say uterine artery, which is the most common artery to form vaginal hematoma. And the most common symptom is pain and difficulty in passing urine. So this scene, especially in hematoma, there will be very pain. Okay, so on local examination, there will be bluish color swelling. So if you see on local examination, there is bluish color swelling, and the management is conservative, that is you will say them to put ice packs or use of some analgesics. Okay, so now coming to indications for surgical management. If the patient is unstable, that is if the patient has gone to shock, or if the size of hematoma is increasing, like if the size of hematoma is greater than 5 centimeters, or the pain is excruciating, that indicates hematoma is extended to muscles. So then in that case we will go for surgical management. So in the case of surgical management, you are going to drain the hematoma. Okay, and if any active bleeding is present, then close a figure of 8 scissors. So active bleeding, in that case you are going to close by 8 sutures. Okay, and obliterate the cavity of hematoma. So in the case of broad ligament hematoma, you need to do immediate laparotomy. Okay, so now coming to a rupture of uterus. So what is the most common cause of rupture of uterus? Most common cause: previous C-section, okay, or most common cause of non-scarred uterus is obstructed labor. That is, other causes may be grand multipara, or maybe Mullerian, or that is Mullerian malformation. Okay, and next coming to sign of impending rupture. Maybe fetal tachycardia, and so we need to monitor fetal heart rate, scar tenderness. Next coming to sign of rupture, fetal bradycardia. Now let us see some other signs of uterine rupture, or that may be maternal tachycardia, okay, or maternal hypotension, or feel the fetal parts superficially, uterus contraction will be lost, and hematuria, fresh vaginal blood, loss of station, if you observe vaginally. Okay, so these are other signs of uterine rupture. Now finally coming to management. So in the management of uterine rupture, you should do immediate laparotomy. Okay, and next try to repair uterus, and next if not possible then go for hysterectomy. So in the case of impending rupture, do immediate cesarean section, so cesarean delivery. Okay, so by this we are completed with our traumatic PPH and episiotomy. Next we'll start with third stage labor and atonic PPH.